Well, again, I'm Dr. Bo Johnson. I'm medical director and founder of Rocky Mountain Vein Clinic. A little bit about myself: I'm a board-certified phlebotomist and board-certified general surgeon. And we started taking care of veins in 2004. The purpose of these webinars or online seminars are to help make our space here in the West a little bit smaller. It's hard for me to get out and get talks personally, and this is a great opportunity for me to be able to stay in one place and everybody else in their homes and listen to a talk about vein disease and hopefully learn something. What I plan on talking about tonight are really give a background and information, basically what are varicose veins and spider veins and why do we get them, what are the symptoms of varicose veins, and since vein disease has changed so rapidly over the last 8 or 9 years, it's hard to keep up with the state-of-the-art treatments, and I have to go over really the newer and most up-to-date treatments and review our approach to vein care, which is a 6-step treatment plan. And lastly, and what seems to be one of the best parts of the talk, is a question and answer session at the end. I should let you know that everybody is muted right now. I can't hear you if you're talking, but you can hear me. And at the end, if you look down on the right-hand side of your screen, there's some little icons down there, and there's a little hand button. If you click that, I can see that you're raising your hand and you have a question. During the talk, it's a little bit difficult for me to have to stop and answer questions in the middle of the talk, so I plan to go through the talk first, and then at the end I'll announce the question and answer session, and I'll just answer people's questions as they come up. And again, if there's any problems during the course of the talk, please use the Q&A box and type a question, and Suzanne, our producer, will see that and hopefully can answer your questions. Okay. Well, first of all, what are varicose veins? The word varicose comes from the Latin word varix, which means dilated. And basically, dilated veins are varicose veins. And what we typically think of in regards to varicose veins are those big bulgy veins that are at the surface of the skin. And that's true. Varicose veins also applies to the deeper veins that are oftentimes the cause of the bulgy veins at the skin. But what causes them, the basic problem is a dysfunctional valve. A little background here to help explain this. For orientation purposes, the top of this picture is towards your heart, and the bottom is towards your foot. What veins do is they take old venous blood, which is blood that's been through the tissues, and the oxygen has been taken out and used for energy by the muscles and tissues in your body. They take that old venous blood and take it back to the heart so it can be pumped through your lungs to get oxygen again, and then be pumped back down through the arteries. What actually pumps the blood are the muscles. When you walk or have muscle contractions, the muscle squeezes down the vein and squirts the blood forward or upward. We're very similar to if you had a tube of toothpaste and squeezed it, the toothpaste would squirt out the end. If the veins were just a hollow tube like a straw, the blood would go up and then come back down with a muscle contraction. So to keep it moving forward, our veins have little one-way valves that look a lot like this. This is a normal vein. When we walk, the muscles contract, blood goes through the valves and they open. And when your leg relaxes, gravity pulls blood back down, and it catches on those cuffs and they snap shut. And that's what happens in a normal situation. When the valves are dysfunctional, that's when we get problems with our veins. This next picture over on the right shows a vein that's dilated, and the valve cuffs don't meet in the middle. And so if you're standing or sitting, the net flow of the blood is down towards your feet, and the blood cools, backs up, and builds up pressure, and that's really what is the start of vein problems. who gets varicose veins? Well, a lot of people do. About 25% of women and about 18% of men. So it's extremely common and probably one of the more common health disorders in our country. The biggest risk factor really is heredity. If one parent has venous disease, there's a 70% chance that the kids will have it. If both parents have it, it's about a 90% chance. What the part that's passed on from generation to generation is a gene that codes for the elasticity of your veins. There's a defect in the gene, and it allows your veins to be a little more elastic than they should be. So if they're stressed by something such as pregnancy or any occupation that requires prolonged standing or sitting, then that stresses the veins and they don't recover from it. So the veins get dilated and they don't come back to the normal position. So that brings us to the other risk factors, which are the stressors. Pregnancy, obviously, if you have several things in pregnancy cause enormous stress in your veins. There's a significant increase in your blood volume, up to 15% greater blood volume, so your veins are fuller. And then as the baby gets larger in the pelvis, it compresses veins that drain the legs and really kind of blocks them, and that makes them dilate, and even more so than they already are. And then after the baby's been delivered, then the veins oftentimes don't come back to the normal size, and you're left with, again, with broken valves. Occupations that we frequently see here in the clinic are teachers by far the most common. Nurses are probably second, and then there's a variety of other people such as cooks and bank tellers, truck drivers, anything really that requires a lot of standing or prolonged sitting. There's other causes of valve damage. Blood clots are a very common one. If you get a blood clot in a vein, it will generally destroy the valve, and when over time your body will usually absorb that clot, and once the vein reopens again, the valve doesn't work. Lastly, trauma is a less common source, but I have seen people that hit with a softball or kicked by a horse or a calf during a branding or something of the sort, and the trauma caused the valve to break, and then over time, then that vein progresses on to being a varicose vein. Well, why do they cause medical problems? You have to start thinking about really what's going on and what's in the veins to help figure this out. I remember I said that what the kind of blood that's in veins is venous blood with very little oxygen in it. So if the veins don't function properly and venous blood backs up, and what's bathing all the tissues in the lower legs is venous blood or low oxygen content blood. And so that really explains a lot of the symptoms that we'll get into here in a minute. But that's really the fundamental cause of the symptoms is venous blood is backing up and not getting back to your heart efficiently. The symptoms are really variable. There's some really common ones that we frequently see. Not everybody has all of the symptoms. Most people have a few of them, and some people have all of them. But the most common thing I see is just a heavy, aching, fatigue feeling, especially at the end of the day. People want to come home and put their feet up, put their legs up. They just feel very tired. It's not really a pain or like if you got stabbed, a sharp pain generally, but there's not a word for it. People talk around it. They say it's uncomfortable, it's not painful, but it hurts. Just have a difficult time describing it. There's just a heavy, achy, uncomfortable feeling. Cramps are another very common symptom. Oftentimes at night, leg and foot cramps or Charlie horses. We see that in probably at least half of our patients. Some have them come in every night with cramps, and you treat the veins, and that goes away. Another surprising one for a lot of people are restless legs. And that's a very common one, and most people we see with restless legs, that goes away once we treat the veins. And it's an interesting one if you think about it. your veins don't work properly. Venous blood cools down in your lower legs. And if you think back to what causes the blood to move out of your legs, it's muscle contraction. So it's really a reflex that your brain senses that that the venous blood is backing up in your legs, and it sends a signal to your legs to move. And that movement helps move that venous blood out of your legs. Itching is another common one, especially in the lower legs. The lower legs is where they tend to get the most abuse from vein disease, because that's the lowest point of your body, and that's where the vein blood backs up the most. So it also backs up into the skin and really starves some of the skin for oxygen, and that's what causes itching. And by scratching it, you're massaging the vein blood out and up, and so it's kind of a reflex. And lastly, one of the most devastating complications of vein disease are venous ulcers. And if you've ever known somebody or if you've had one personally, it's a very painful problem to have. The skin is unhealthy from venous blood backing up in it. And you get some sort of a small trauma through the skin, and it doesn't heal well, and it just progressively gets bigger and bigger, and it takes months and months to heal, and it's oftentimes very, very painful. The symptoms are usually made worse by prolonged standing or sitting on, say, a car trip. People will tell me that if they have vein disease, if they travel by car, that they frequently stop, and they don't know why, but they say, we always stop every hour just to get out and walk around a little bit. Leg elevation also is something that people do with vein problems. They automatically just go home, put their legs up because it feels so much better. And compression stockings, which most people don't like, but people with vein problems, once they get over the trauma and difficulty of putting them on, they sure like the way they feel. People without vein problems don't like to put them on, and they don't like them when they're on. They don't like anything about them. So that's another good tool to help see who has vein problems. Well, I try to take a stepwise approach to vein disease. And the first thing really seems pretty straightforward, but oftentimes is the most difficult, is symptom recognition. A lot of people come in with very significant vein disease, and they'll tell me their legs don't bother them. And a lot of this is because of the way vein problems come on. They come on very slowly over about 15, 20 years, and everybody's got an excuse for them, and they're pretty common vague symptoms like aching, heaviness, fatigue, and a lot of people, I'm just getting old, or like they say their mom had cramps, that's why they have them, but in reality their mom probably had vein disease, and that's why she had cramps as well. So it's a very challenging part of this process for me, is to help the patient identify their symptoms. The most important part of this, really, and it really tells me what's going on, is the ultrasound. And you really need a very detailed and thorough ultrasound that's very different than what you would get at the hospital. It's a vein mapping, actually, of all the major veins in both legs. And that really tells me which veins are leaking, what they're connected to, and really allows me the ability to plan out a good treatment for you. Once we know what's going on, then I try to spend a lot of time educating each patient about vein disease so that they can really make an active or have an active role in their treatment plan. And I think that's really important, that people are engaged in their treatment. Generally, there's several different options. Sometimes if there's one that's better than the other, I will indicate that. But usually people should, if it's 6 one, half a dozen the other, I think the doctor shouldn't be telling the patient what they have. The patient should choose what's best for them. And if I've done my job, you're able to make that decision soundly. The next step, I think, if you have vein treatment, it should be by someone who's committed to vein care. Somebody who's been trained in vein care, like somebody like a phlebologist, which is probably a new word to a lot of people, but it's the specialty of doctors that take care of veins. blood means vein, and the ologist is the person who studies that, or surgeon. And lastly, because this is a genetic problem, I think it likely won't be your only problems. The only time you'll have problems with the veins. If I just treat somebody and wave goodbye when we're done, it's not likely going to be the end of the problems. And I think that a long-term plan is really in your best interest. What we try to do is, once we've completed the treatment, try to set up a follow-up in 6 to 12 months. It usually involves an ultrasound, which really will tell us again how things look and if anything else has progressed, and then a visit with one of our clinicians to see if there are any symptoms. So that's really our main treatment pathway. One question that's frequently asked of me is that by patients and other physicians, and they don't realize that this is covered by insurance. It's a medical problem, and virtually every insurance company covers this. Well, let's move on to the procedures. How they used to be fixed, and unfortunately there's still a few people that have this done. But stripping is what I'm sure many of you have heard about and probably heard the stories about it. But that involves a procedure that you do in the hospital, in the operating room with the general anesthetic. There's generally a 3 to 5 day hospital stay and a 6 to 8 week recovery period, and it's really quite painful afterwards. A device is run up the vein, usually the vein in your thigh called the saphenous vein, and the vein is tied to that device and then it's just pulled out. So there's really anybody that has had a recommendation for stripping should consider one of these newer endovenous procedures. I just can't think of any setting that stripping should be used anymore. Endovenous means inside the vein. So really the way we treat veins now is endovenous ablation, and that basically means we put a catheter inside the vein and run it up through the length of the vein, and the catheter generally gets hot, and then we pull the catheter out slowly, and as we do that, it just seals the vein shut from the inside. This little cartoon down below demonstrates that, and this actually shows a laser fiber that basically a fiber is put into the vein, and we put some numbing medicine around the vein so you don't feel anything, and we turn the laser on, and then slowly withdraw the laser fiber down through the vein. And you can see that as we do that, the vein shrinks and seals shut. And then when you're completed, you just have a small little band, and over the course of the next 6 months, your body will just absorb that. And frequently, we aren't even able to see it by ultrasound in 6 months, which is pretty amazing. These newer treatments are minimally invasive. We do them in the office. We use local anesthesia, which means we just put numbing medicine in the skin, and we don't use a general anesthetic or sedation of any kind. About half the people will take a small dose of Valium if they have anxiety or nerves about it. But I leave that up to the patient's discretion. If somebody thinks that they need the Valium, then they take it, and if they don't, we don't make them take it. Activity afterwards is encouraged. I want people to be walking every hour. I don't want people to be thinking they have to sit for long periods of time and have a long extended recovery. It really shouldn't interfere with your daily activities much. There is some mild discomfort afterwards. It's often described to me as maybe a bruised feeling. Occasionally somebody will have an exaggerated inflammatory response that we usually treat with some ibuprofen, but most of the time, most people have some discomfort afterwards, but it shouldn't keep you from doing the things you normally do. There's 2 types of technologies that are used currently to treat veins this way, and they both do the same thing. They generate heat, but they do it by a different mechanism. The laser generates heat by using light energy, and the other technology is called radiofrequency ablation. And it just uses radio frequency energy to generate heat, and it does the same thing. Basically, it damages the lining of the vein and causes the connective tissue in the vein wall to contract, and so the vein compresses down. We usually need to combine these with other treatments because if you have one long vein in your thigh, every vein that's connected to it down your lower leg is probably dilated as well. So we treat the source of the problem first with these endovenous ablation techniques, and wait a little while, usually a month or so, and then follow it up with an ultrasound and see really what's going on. And most people will need something along the lines of sclerotherapy, where we do injections to treat those veins. And oftentimes at the same time as we do the ablation, we'll do what's called a microphlebectomy. And that's where we take out the large superficial veins, those big bulgy veins that you think of as varicose veins, that are on the surface of the skin. I'll talk about more of these both in a few more slides. And then lastly, again, long-term follow-up is key. So I'd like to show a couple of videos. This first is a cartoon, and it just demonstrates radiofrequency ablation, but really the laser is the same concept. We're both putting a catheter in the vein and using heat. I'm waiting here. Looks like about 80% of the people have this video downloaded. In just a second here. I'm going to go ahead and start this video. And I'll narrate it. First, a catheter is put into the vein, and this is the catheter being passed up the vein from usually around the knee up to the groin area. We use ultrasound to guide everything we're doing. So once the catheter is in place, we put some numbing fluid around the vein, and that's what that needle is showing, and the numbing fluid goes in and numbs up the vein and compresses it down on the catheter. Then we turn the catheter on and slowly remove it. And as I do that, it heats up the vein and causes it to contract. This shows those collagen fibrils, which is probably part of the connective tissue. Shows how the heat causes those to shrink down. And this is their interpretation of what it looks like inside the vein. But we keep pulling that out until we get to the end of the vein, and then when we're done, the vein looks like just a little fibrous band. Now the next video, this is a patient video of a couple of patients that had these procedures done here in our clinic in Billings, at the Rocky Mountain Vein Clinic in Billings. And this is really two patients, and one's having the laser and the other's having the radiofrequency ablation. And really, if you're the patient, you won't know the difference because you won't feel any different. The only difference depends on what catheter I put in the vein. But I'll go ahead and narrate this video. But this is really a typical experience of what it's like having the procedure done. You come in, the first thing you do is have the technologist map the vein, and she'll use little straws to make dimples on your leg over the vein, and she connects those dots with a Sharpie so that there's a line over the top of the vein so you can see where the vein runs. And then the next thing we'll do is put a special antiseptic soap on your leg to prevent and reduce the risk of the infection. And you just prep the leg out like we do in the operating room, and do this under a sterile procedure. Put some sterile drapes around it so there's all those blue things you see. And then I look at the vein and make an assessment and really look at the treatment plan and get it figured out exactly where we want to access the vein. And then I have to numb up the skin. That's the only part that really hurts. Right there I'm putting some numbing medicine in the skin. That stings and burns for about 5 seconds. And then we use the ultrasound to help me guide a needle under the vein. And this part really doesn't hurt. It's already numbed up, so you don't really feel anything but just some pressure on your skin. But that ultrasound really helps me locate the vein, and this is what I'm looking at. The needle is going into the vein. The vein's that black tube you see there, and the needle is is what's moving there, but I can very accurately see where the vein is and put the needle in. And then through that needle, I put that little guide wire, which acts as a guide for me to run a catheter down. Now, this is the catheter for radiofrequency ablation, but we just slip that over the top of the wire. And again, you don't feel this because the skin's numb. This is a laser fiber, and that's for and that's the radiofrequency catheter right there. So those are both the treatment catheters. We just slide it up the vein, and again, I'm using ultrasound to guide everywhere the catheter is going. What you don't see is the ultrasonographer is showing me a picture on the screen, and I'm watching very carefully where we're putting this. And we position it so that it's just back from where the vein originates. And this is really what it looks like for the radiofrequency ablation. The procedure part is pretty simple. I have to put that numbing fluid around the vein. And most people will feel this, but it's not really painful. People say it feels strange. You can see by the patient there, she's watching what we're doing and really not having a bad time. But we put that fluid all around the vein, so it compresses the vein, and it also makes it so we don't feel it when we treat it. It also acts as a cushion around the vein. It's a kind of cool fluid, so any heat that might get out of it outside the vein gets absorbed rapidly by all that fluid. I'm actually doing the treatment part here. The handle has a little white button I push, and you just push it and treat for 20 seconds, and push on your leg and then move it back another 7 centimeters, and it's just about a 3 or 4 minute process where we actually treat the vein. And again, you don't really feel any of that. It's probably the least exciting and least painful part of the whole procedure. When we're done, we check the ultrasound, and that shows that the vein's been closed and that there's no problems with the deep vein system. And then we'll clean your leg off, all that soap that we put on. We'll get it cleaned off, and there's the access site, and that's it. We put a little Band-Aid on, and then your stocking goes on, and get that situated so there aren't any wrinkles or anything that would bother your skin. And then that's the patient going in the procedure room. And when we're done, we have patients walk for 5 to 10 minutes on the treadmill just at a slow pace, or if they have trouble with the treadmill, walk around in the clinic just to get the blood moving in their legs, and it reduces the risk of having blood clots afterwards. So it's a pretty simple procedure that people tolerate really quite well, and it's not really a horribly painful experience. The other procedures that I mentioned, I'll talk a little more about here. Ambulatory microphlebectomy is kind of a mouthful, but basically that means microphlebectomy means we make very small incisions, really 1 to 2 millimeters in size, and phlebectomy means removing veins. So this is really what we use for the big superficial veins that are the branches of the veins that we close with the laser or the radiofrequency catheter. If we don't remove these, oftentimes they'll clot, and those aren't the clots that cause you problems like a deep vein clot that can move around and go to your lungs. But these are right on the veins that are near the skin. And what happens when those clot, they get very, very tender and hard, and then they can cause a lot of pigmentation when that blood clot starts to dissolve. So if you have large superficial veins, it's oftentimes better to get those out at the same time. We'll close the big vein first that created them, and then we'll remove these afterwards. Now this sounds really terrible, but it's really not a bad process. The only part that's uncomfortable is when I have to put the numbing medicines, the same medicine that we put around the veins when we treat it with the laser. And I put that around these veins, and usually about 3 to 5 minutes, and we're done with that part, and the rest of it is really just quite boring, and a lot of people fall asleep. You just feel pressure on your leg. You don't have any pain after we put the numbing medicine in. I use a small needle actually to make these incisions with triangular holes near the veins, and then we use a little instrument to grab the vein, and we actually remove them with a series of small little poke holes. As I mentioned earlier, you really will get a better cosmetic outcome afterwards if you have those large bulgy veins. Even though it may be just a little bit more tender the first week, in the long run, it'll feel better more quickly if you have that condition. Sclerotherapy is another very, very common tool that we use. The veins that aren't suitable for phlebectomy and the laser treatments are usually the veins in the lower leg that are really they leak as a result of having had all that pressure on them from those big thigh veins that have been leaking. There's two types of sclerotherapy. There's visual sclerotherapy, and that's where I use my eyes to localize the vein and put a needle in it and inject some medicine that does the same basic thing as the laser does. It injures the vein and makes it contract down, and then over time the body will absorb it. And then there's what's called ultrasound-guided sclerotherapy, and that's where we treat the veins that are a little bit deeper in the skin that I can't see with my eyes, but we can find them with ultrasound, and we inject those with the same kind of medicine. But this patient on the right shows a real typical response before and after sclerotherapy. So the other supplemental treatments for spider veins, again, the ultrasound foam sclerotherapy and visual sclerotherapy. And we, within the last year, purchased another laser called Gentlemax laser, which is a cutaneous laser. And what that means is I hold the treatment device in my hand and we put it on your skin and fire the lasers. The other one is endovenous, meaning inside the vein. This is on top of the skin, and it's just an excellent treatment for small spider veins that are 2 millimeters or smaller. So once we've treated all the larger veins and there's still spider veins left, this is a really good option. I thought what I'd like to do now is go over a few patients, just typical patients that we see, just to give you an idea of what it's like to go through this and to see some typical patients. And this first patient is just a classic patient for us. She's a 36-year-old teacher, mother of 3. Her mom and her grandmother both had vein problems, and her mom had vein stripping. She presented with classic symptoms of aching, fatigue, cramps at night, restlessness, and a little bit of swelling at the end of the day. On her exam, I found some large, ropey veins that were on her right leg just below her knee, and she had a little bit of swelling in her ankle on the right side. So we performed an ultrasound, and surprisingly, even though we saw the ropey veins in her right leg, she only had one dysfunctional vein in her right leg, with 2 in her left. And when I asked her her symptoms were equal. So this is a real good example of somebody who would come in and say she didn't have vein problems in her left leg, and she only had them in her right because that's where she could see the veins. But when we did the ultrasound, it turns out her left leg probably was a little bit worse. We closed the veins in both of her legs with radiofrequency ablation, and for those large bulging veins in her right leg, we did a microphlebectomy, and then about a month or so later, she had some of the ultrasound-guided sclerotherapy in each leg to close some of the smaller veins in her lower leg. Afterwards, she was pain-free, very happy, and this is what we hear over and over again, is that her legs have more energy and they feel much lighter, and she is very glad that she had done this. This is actually her legs, and what I'm going to try to do is try to enlarge this picture, these next several pictures, so you can see it a little better. But as you can see on her leg, these are these large ropey veins. It's kind of hard to see in the photograph, but they're more impressive in person. But those are the large veins in her right leg. And her left leg, you can see there's not even any spider veins. But her symptoms were equal, and ultrasound showed significantly more problems in her left leg than her right. This is when they're done. This is about a month later, and right here you can see little fine ink dots. That's where the microphlebectomy was. But really, after 6 months or so, that fades and you can't even see it. This next gentleman is one of my favorite patients. He came in saying he didn't have any vein problems. His legs didn't bother him. His wife made him come in because she thought that his veins were going to give him some health problems. So begrudgingly he came in and was really sincere initially that he didn't have any vein problems. But he did admit finally that after working all day, he did need to put his legs up at home and in the evenings. And once he wore compression stockings, he did notice a significant difference. But we did an ultrasound on him, and really he had two veins in his thighs. They're again called the saphenous veins, which are the veins that run right up this way. He had one in each leg. That was the source of all these big bulgy veins down in his lower legs. So we treated him with radiofrequency ablation. We closed both of those veins. And then on these big ropey veins, we did a microphlebectomy. And his legs afterwards really had a tremendous response. And he was very happy afterwards, and we couldn't believe how much different his legs felt and how much better they felt. The next person here, she is a nurse who's 42 years old. Her biggest complaint was that vein that runs down the left side of her leg right here was ache and throb towards the end of her shift, and it really was getting to the point where she would have to sit down. And she also had some cramping and some restlessness. But the thing that really bothered her was the throbbing and aching of that vein. She had an ultrasound and again had that same vein in her thigh and one in her calf that we treated with the laser. And this is her picture afterwards. And she afterwards had a little bit of bone flare therapy as well. And she was again very pleased with how her legs felt. Last here is a 52-year-old cook that worked at a school as a cook. And her complaint was a heavy aching feeling in her leg. And then these big bulky veins really ached and throbbed. Stockings made her feel a whole lot better. She had, both legs actually had a vein that we treated in. The ultrasound showed again that thigh vein and a calf vein were her problem in her left leg, and one vein in her right leg. We treated her with a combination of the ablations and then the microphlebectomy again here. Here's her picture afterwards, and another happy patient. So, yeah, I thought about, what are some things, what are 6 or 7 things I could tell you that really pearls of wisdom that you could take away with you. The first thing, if you see bulging veins, you have vein problems. And you can't get big bulgy veins on the skin and not have underlying vein problems. So, it's just, it goes hand in hand. However, a corollary to this is you don't have to have big bulging veins to have vein disease. If you have the symptoms, you really should get an ultrasound because if you have those symptoms of heaviness, fatigue, aching, bulging vein, cramping, and restlessness, you're going to get bulging veins on the skin at some point. It's just they haven't gotten there yet. So the only way really to find out is the next bullet down is a specialized ultrasound. And again, that's not something you get at the hospital. At least it's a vein mapping. It takes about an hour, sometimes longer, and it's a complete ultrasound of all the major veins of your leg, and it produces a vein map. This next bullet point down, this is something that many physicians and most people don't understand. This is a medical problem. It's not a cosmetic problem. I mean, you do get a cosmetic benefit from treatment, but it's a medical problem that causes significant changes in daily life, heaviness, aching, fatigue, just like a toothache. You're not going to die from a toothache, but it sure feels good to get it fixed. I frequently hear patients come in and will tell me that they've been talking to their doctor about their veins for several years, but he told them, "No, don't worry about it." And that's what I would tell people too before we had these minimally invasive procedures, because you have to be pretty bad off to recommend stripping for somebody, because the treatment was such a big deal. It was oftentimes worse than the disease process. But now, with these new minimally invasive office-based procedures, the question is, why would you not fix it? I mean, it makes no sense, because you look at a significant improvement in the way your legs feel. This is another one that is frequently misunderstood. Insurance almost always covers these procedures. Sometimes they'll put up a little bit of a fight, but we will just remind them with a letter that this is that you have symptoms. You have an ultrasound that shows significant leaky veins. And one thing they will do, however, is they will require an attempt at conservative management, which means they want people to try compression stockings for 3 months, sometimes 6 months, usually around 3 months. For what reason, I don't know. It has no impact on their care. It's just, I think they're hoping that maybe some people won't do it if they have to wear stockings, but I've yet to have a patient do that. But we almost always cover these. Symptoms are most often underestimated, and then I just know that from treating a lot of people that they come in and really trying to downplay their symptoms, and oftentimes we most frequently treat both legs. So we treat one leg, and there usually is a month or so in between treatments, and during that interim they come back and say, well, I can't wait to get my other leg fixed because I didn't realize how bad they were hurting. So they're usually underestimated. And lastly, I'm a general surgeon, and I treat a lot of bad stuff, colon cancer and gallbladder problems and appendectomies and all kinds of things that the people are pleased with their care, and they say thank you, but the vein patients are the happiest by far I've ever treated. So I know we're making an impact on quality of life, and people really appreciate it. Lastly, I'll just go over our process again: symptom recognition, an ultrasound exam, a physical exam, patient education, choosing a treatment plan, treatment by somebody who has specialty training, and then follow that with a long-term care plan. Well, that concludes my talk portion of this. If you have questions in the future, please feel free to contact me with a variety of ways. Our billings office, Cody office numbers are there. My website is RockyMountainVeinClinic.com, and that really has a lot of information about venous disease in general. It has a lot of videos, and I really try to use that as a source of education for my patients. We have an email, info@RockyMountainVeinClinic.com. And we also have a Facebook page which we update regularly, and has a lot of case studies and any kind of new information, so you may want to follow that if you use Facebook. And lastly, before I open it up for question and answers, we'll be sending out within the next 24 to 48 hours a survey, and I'd really appreciate it if you take the time and fill that out. It really helps me tailor these talks to you so that they're more useful. It would be a waste of your time if they're boring. And so if you would really fill those out and send them back, I'd very much appreciate it. So I'll open this up for questions. And again, I'll remind you how to do that. There's a little hand button. If you click on it, you can see by my name, the little hand pops up. And I will unmute your mic. And then you can ask me a question and I'll answer it. So I'll wait to see people's hands. Okay, just a second here, Doreen. Okay, Doreen, can you hear me?
Yes, I can. I enjoyed the presentation. Thank you so much.
Oh, you're very welcome. What question do you have?
I was wondering, with the different types of laser, is there sometimes scarring on the skin with that? Could you talk about the aesthetics with the laser?
Sure, and I'll leave your microphone open. With the cutaneous laser, there's literally hundreds of different types of cutaneous lasers. And how they work is they target a certain wavelength. It's called a chromophore. So if they're not used, anytime you use those lasers, you can adjust the energy. So they can, sometimes you can get a little burn with them. They can cause pigmentation afterwards. And even if you use them properly, sometimes they can do that as well. So it's not real common, but yeah, you can see some scarring with the cutaneous lasers, and that's, again, different than the ones we use inside the veins, which are the venous lasers.
Oh, thank you. And one other question: are all of these procedures covered equally by insurance, or are any of these considered, I guess, not fully, tested and qualified, or such that they aren't covered with the same percentage level when you start thinking about your out-of-pocket expenses?
The cosmetic procedures are not covered, and what they consider cosmetic is generally the cutaneous laser. So when we treat spider veins with the cutaneous laser, or if we do what's called visual sclerotherapy, where I use my eyes to find the vein instead of the ultrasound, that's generally considered cosmetic, and so they won't cover that, rarely if ever. The varying degrees of coverage, insurance is very complicated, so we always try to help people when they go through this to figure out exactly what percentage is yours, what's insurance. But every policy, even if you have a Blue Cross policy, and you might be on a different group, and so some groups within Blue Cross don't cover the same as other groups of Blue Cross or EDMS. So in my experience, there's no way you can really tell up front unless you come in and see and start the process. And then at least you know what you have, and you can see what they'll do, and there's nobody holding a gun to your head making you do it. I mean, it's not a... You get enough information that then you can make it your own decision. But it's hard, if not impossible, up front to call them and say, how much this do you cover? Then they'll say, well, what are we going to do? And they'll say, well, I don't really know because I haven't seen the doctor yet. And so you don't really know until you know exactly what you're going to have done.
Especially after that sauna, the similar stuff is done, and you can map out and you know how many are bad and where for the valves.
Exactly, the ultrasound. And that's really that tells you what's going on.
Okay, and then, oh no, I think I might have just forgotten my last question. Oh, so even though insurance might not cover the sclerotherapy, for example, addressing that cosmetic nature on the legs is still good from the standpoint that we'd know that we don't have any additional underlying conditions. It's almost like starting with a clean slate moving forward in terms of your maintenance and watching the health of the leg. Okay.
Exactly, that's right. And even if you have spider veins, vast majority of people, it's a rare person that has just spider veins. Or it's usually what causes them is pressure on the veins, and what causes pressure on the veins are the larger veins have dysfunctional valves, and so it's kind of the tip of the iceberg. So the sclerotherapy you mentioned, if it's visual sclerotherapy, that's cosmetic, but really if you get an ultrasound and you find out that you have some of these bigger problems, if you treat those, you do get a cosmetic benefit, and especially when we do it's called the foam sclerotherapy or the ultrasound-guided sclerotherapy, that generally is covered by insurances. Sometimes they put up a little bit of a fight, but generally they will cover that, and you can get a significant cosmetic response to that. But my goal to do that is primarily medical, and then afterwards, cosmetic is important too. Of course, I want your legs to look good, but my goal is to make them feel good at first and have a long-lasting effect, and you do get a significant cosmetic benefit.
Thank you. That's all my questions. Much appreciated.
You bet. Thank you for your questions. Okay, it looks like a friend here is with a question. Margaret?
Hi.
Are you there?
Yep, I'm
here.
here.
How are you doing?
Oh, good. I just wanted to thank you for how much better my legs do feel after all that treatment. My question is, long term, is there anything I can do to keep my legs from or my veins from going back to the way they got before you did the procedure?
Yeah, yes, Margaret. That's part of why we see you back frequently.
Yeah.
We like to see you for one because you're a lot of fun, but more importantly, if you remember, it's a genetic problem, and so you're programmed for this. All your veins are. So when you have the big, long, leaky veins that you've had before we treated your legs, that accelerates the process because that's what puts a lot of pressure on them. So when we close those, it slows that process down. But long term, I'm sure I've encouraged you to wear your compression stockings when you can, and then have an ultrasound, every 6 to 12 months, for a while anyway. If you have 2 in a row that are normal, then obviously we're going to make it every couple of years or something. But what really happens, and you're a good example of this, is people call us back once you recognize those symptoms. When we treat you, they go away, and as soon as you start to notice them again, people call me back very quickly and say, I'm getting cramping again, I need an ultrasound. And they're always right. I mean, it's interesting. So people come back on their own, or we'll schedule them for 6 to 12, 18 months, and see how they're feeling afterwards. And check those ultrasounds and make sure if something's going on, then we'll go ahead and do usually some sclerotherapy at that point. But sometimes, if we treat the thigh veins, sometimes the calf veins will go bad 2 or 3 years later, and we have to treat those with the laser again. So you don't really know unless you check with an ultrasound.
Yes. Well, I notice sometimes my veins, like if I hit my hand or something, they will break easily. Is that something that is generally characteristic of all the veins in my body?
Probably. I mean, one of the things with your hand is that those veins are very exposed and not well protected because there's just skin over the top of them. So those are going to damage a little more easily. But in general, people do have frail veins that rupture easily, and I've seen many patients that came in because their veins keep rupturing and they get these big bruises in their legs for no really apparent reason, no trauma. They'll rupture and they cause tenderness and bruising.
Mm-hmm. Well, that's all the questions. I just wanted to thank you again. I was resigned to having hurting legs all the rest of my life, and now I don't.
Oh, I'm glad. It makes me feel good to hear that. Thank you.
Thank you.
Okay. Are there any other questions? I'm going to go ahead and mute you, Margaret. Anybody else have questions? Now, last time we did this, I had probably 35 minutes worth of questions, so if you can ask anything. It's a great opportunity to talk with the doctor and find out if you have a problem or not. Well, I don't see any other questions. I'll leave it open a little longer. Well, while we're waiting to see, I just would like to thank everybody for attending, and remind you that feel free to call or either office. Either myself or my staff would be happy to answer any questions. And again, ask you to please fill out the feedback form. It's very helpful to me and helps me better tune these in so that they're more useful for people when they're watching. And if you have suggestions for other topics that you would like to hear, I'd be glad to consider that. Well, since there's no more questions, this will conclude our webinar or online seminar. And thank you for attending. Good night.